Hi, I've seen firsthand the breakthrough when AI is done right and the risks when it isn't. Welcome to week 2 of our AI summer series, Summarization. Hi, I'm Teresa Yunkin. I'm a health informaticist and an AI strategist. I've trained executives, I've led AI pilots, I've driven national conversations around fire and governance. And what is my mission? Well, just like a surgeon stitches people together in healthcare with needle and thread, I try to stitch the people and the processes together with ones and zeros. Let's dive into this week. Now, if text generation is the gateway to using AI, summarization is going to be your accelerator. Summarization is what makes information usable and fast. It's how that 3-page clinical note becomes a 10-second scan for a physician. And in healthcare, time isn't just time. It's attention. It leads to burnout. It leads to missed diagnoses. And for patients, it's how much time do I have to take off from work? What do I need to digest? And how many questions do I need to have answered before I know what to do? And for caregivers, it's how much information do I need to collate across different EHRs to pull these together and really understand how to take care of the person that I love the best. Studies show that AI summarization tools are now matching, even outperforming sometimes medical experts. And they're doing it around areas like those key documentation tasks, discharge notes, progress summaries, after visit summaries. One NIH study adapted models actually outperformed medical experts in 36% of the cases, and then it matched them across 45% of clinical summaries, like those progress notes and discharge summaries. I'm not talking about cutting corners. I'm talking about cutting through the noise so that clinicians and patients can focus on what actually matters. Let's look at what is happening in major healthcare systems right now. Researchers at UCSF, or the University of California, San Francisco, they ran a blinded study and comparing hospital discharge summaries drafted by attending physicians versus those that were generated by LLM. They sampled 100 inpatient cases from 2019 to 2022. They had physicians review, evaluate these summaries for quality, coherence, conciseness, and safety. The results? Well, the LLM generated summaries were rated as high quality and they were preferred at similar rates to physician versions. In fact, these LLMs were often more concise and coherent, and they actually had no increase in overall potential harm. Picture this. An AI hospitalist is wrapping up a multi-day inpatient stay. The LLM is going to draft a summary. That doctor is going to review it and edit it. And then that summary is going to hit the patient's chart hours earlier and sooner than usual. It's because the doctor is not having to think about, right? They're not having that cognitive burden to have to think about all the things that happened because they were recorded. The note itself can generate that lift for the physician, and then it can actually get it out faster once the physician reads it. I'm going to caution you here. We must always have a human in the loop. I say that each and every week when I talk about AI in healthcare. The follow-on benefits for that workflow using AI is families are going to receive clearer notes and the care teams can sync up earlier. And the hospitalists can actually breathe a little bit easier knowing that that documentation is reliable and efficient. I've always said, clinicians don't get into medicine to become documentation experts. A lot of people get into medicine because they want to care for, care about, and help people. This is one way to help avoid burnout and help clinicians get back to their why. Now let's flip that perspective because summarization isn't just for physicians. As a caregiver, I have sat in those visits where the provider says a lot. And when you get home, you get a minute to process everything that's gone on. You've got more questions than you even started with. And the after visit summaries that we normally get are usually 5 pages long, tiny font. They're full of clinical language. And we're supposed to understand this and then expect to turn all of that clinical speak into actions. There is a tool that Dartmouth developed called the Dartmouth Orals Project. I'd like to bring this into comparison when the patient is receiving this clinical documentation and what they can actually do with it. This is where tools and projects like Dartmouth's Orals projects comes in. So ORAL, ORALS, stands for Open Recording Automated Logging System. So it uses speech to text and machine learning to record, transcribe, and automatically tag key parts of the visit, like the diagnoses, medications, and any sort of next steps that are discussed. That way, patients can revisit actually what was said, and they can do it on their own terms. And they can even share tag sections of that conversation with their family members or caregivers, the people who are bringing them support. It was actually co-developed with patients, caregivers, clinicians, and medical students to make sure that it actually worked for real people. And the impact of that, well, there's better recall, better adherence, and more confident follow through on both sides. For any family that's ever had to manage a transition of care from a clinic to the home, you understand that clarity can reduce stress because it's reducing cognitive load. You're being told what you need to do in a way that's easy to understand. And because of that, that improves the safety of what happens when you get back into the home, and it can prevent any unnecessary return visits. So, how do you actually use AI for the summarization in practice? Well, it starts with asking the right questions and applying the right frameworks. I use something called FRAME to guide summarization in healthcare. F stands for focused. What's the point of the summary? R stands for role sensitive. Who's it for? The clinician, the patient, or the caregiver? A stands for actionable. What's the next step someone needs to take? 4, it's measurable. It's concise. It's complete. You can check a box. And then the fifth one is E, evidence aligned. Does this stay grounded in the original data? For example, I'm going to show you frame in action using a primary care visit, first from the clinician point of view and then from the patient point of view. So the case study here, imagine a 67-year-old patient with diabetes and high blood pressure comes in for a quick checkup. Your provider, of course, is going to review the labs, adjust the medication, refers the patient to ophthalmology for their eye check, and then sends a follow-up in 3 months. So the patient needs to come back. This is how a clinician summary would look if we were using frame. Patient's A1C increased from 7.2 to 8.1%. Metformin dose increased to 1,000 milligrams BID. Referred to ophthalmology for annual retinal exam. Encouraged improved dietary control. Follow-up in 3 months. Continue lisinopril 10 milligrams daily. That note in itself serves the clinician and the hospital system because it's focused on medical changes. That note's written in a role-sensitive way for any provider who's reviewing the chart, right? It's actionable, it's got clear next steps, it's measurable, it's about 120 words, it's EHR aligned, it's evidence aligned, and it's sourced from clinical notes and labs. It's great for the clinician. It's not great for the patient. Now, here's the patient version. Your doctor adjusted your diabetes medication to help lower your blood sugar. You now take metformin 2 times a day. You need to schedule an eye doctor appointment. You need to eat fewer sugary foods, come back in 3 months, keep taking your blood pressure pill once a day. That's written in a way that any patient or caregiver, when you get home, you read and you understand what you're supposed to do. It's because it's written at a grade level that's easy to comprehend. It reduces that cognitive load. It highlights what's new and what you need to do. It's easy to share with anybody in your family, and it keeps the language plain and anchored in fact. That is what good summarization looks like. It's not just condensed, made shorter. but it's clear, it's useful, and it's role specific. It's not shortening. Right now, we're stitching context back into that care conversation between provider and patient. AI summarization, it's not just about making things shorter, it's making the right thing stand out for the right people at the right time. So, whether you're a clinician reviewing charts or a caregiver trying to remember the next steps after a really hard appointment, the power of summarization is the clarity that it brings to it. Tools like Dartmouth's Orals Project and LLM powered discharge summaries, it's showing us that when AI is done well, it does not replace the human side of care. It makes space for it. And that is the leadership opportunity to turn summarization into trust, into insight, and into shared understanding. Next week, we'll explore classification. And that's how AI can sort, tag, and structure that flood of clinical data in real time. Until then, if this episode helps you think differently, I want you to hit like and subscribe, share it with your team. And if you're ready to build AI into your real world workflows, you don't know where to start, you don't know what should be your priority, you're not even sure if AI is a good fit for you, you know where to find me right here each week talking about it. Reach out to me via DM and I'd be happy to have a conversation with you. All right, guys, we'll catch you here again next week on the flip side.